Okay, good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Feel free to ask questions in the chat box as we go along, and your questions will be addressed. So this month, we are kicking off Pulmonology Month, and today we're going to be doing an introduction and case studies, wrapping up from Cardiology Month from last month. All right, so first we're going to introduce the respiratory system and exactly what the field of pulmonology actually is and what it means. So, pulmonology is a medical specialty that focuses on diagnosing and treating diseases of the lungs and also the respiratory system. It's basically a medical specialty that deals with diseases involving the respiratory tract. It's also known as respirology, respiratory medicine, or chest medicine in some other countries and areas internationally. And what exactly does a pulmonologist do, you might be wondering? Well, pulmonologists, they are basically physicians who are specially trained. They're medical specialists in the field of pulmonology to treat conditions like asthma, emphysema, tuberculosis, pneumonia, and also complicated chest infections. They may also treat conditions caused by inflammation, tissue overgrowth, infections such as bronchitis, chronic obstructive pulmonary disease or COPD, also cystic fibrosis, interstitial lung disease, and also lung cancer. And also, a pulmonologist is a physician who specializes in these respiratory conditions and the overall respiratory system. So, from the windpipe to the lungs, if your complaint or medical complaint involves the lungs or any part of the respiratory system, a pulmonologist is a doctor that you want to solve that problem. So, according to the American Lung Association, this is exactly how to become a pulmonologist. Basically, pulmonology, as we discussed before, it's a field, as a medical field of study within internal medicine. And these doctors, they go through the same training as an internist or an internal medicine residency, and then they go into a fellowship with pulmonology. So these doctors, after completing medical school and then 3 years of internal medicine residency, they receive their degree, complete their internal medicine residency, and then spend a couple of years as a fellow focused primarily on pulmonology, which often includes critical care and also sleep medicine. After that, they have to take and pass specialty exams, and only then are they able to take patients as board certified pulmonologists. So while the respiratory system is a specialty in and of itself, pulmonologists can specialize even further. Some of these doctors, they focus on certain diseases like asthma, pulmonary fibrosis, and COPD, like we discussed before, while others treat unique demographics like pediatric patients or geriatric patients. And so because many lung and heart conditions present similar symptoms like chest pain, pulmonologists often work with cardiologists while diagnosing patients. So you'll often see them working in hospital settings, patients that are working with patients who need life support or manual ventilation in order to breathe. They'll also have a pulmonologist overseeing that element of their care. So basically, pulmonologists, they work with chronic breathing problems or people or patients facing serious breathing problems. Because while primary care doctors, they can handle mild or short-term conditions like those caused by colds or respiratory conditions or the flu, you'll need to see a pulmonologist or a specialist to diagnose and treat and manage more complex illnesses that primarily affect the lungs. So if you're struggling with respiratory disease, the accurate diagnosis is the first step, which would be done by a referral from your primary care physician or your general practitioner. So the pulmonologist would use procedures when they see you, like a spirometry, will learn about blood work, chest x-rays, they can do CT scans, bronchoscopies as well, and also sleep studies to diagnose your chronic lung disease. Your pulmonologist can also ask you to repeat these tests if you already had them and also confirm those results. So once you do have a diagnosis, the pulmonologist will treat you in accordance with your treatment plan. And if you require surgery, it will be done by a surgeon who specializes in the heart and lungs. So that wouldn't be done by the pulmonologist because their training isn't in surgery per se. It's more so in medical management of the lungs. So beyond that, the pulmonologist will use medications, therapies, and also pulmonary rehabilitation to help you return to wellness. So it is actually it's a very interesting field. If you're interested in lungs or anything we discussed today, they're very common diseases that are treated by pulmonologists. Now, it's not going to be an exhaustive list, but it will be quite a few, such as, and also another thing I wanted to mention that pulmonologists in the healthcare team, they also work with respiratory therapists, asthma educators. They also work with pulmonary rehab programs and also local support groups, like the American Lung Association's Better Breathers Clubs. They also help patients who might be experiencing some inflammation from smoking. So they want to work with different therapy groups to help with smoking cessation as well. So overall, this is a quick snapshot of what a pulmonologist does. I'll be going into a little bit in depth of the anatomy and physiology of the lungs shortly, and also some common diseases, the pathologies, and a couple of case studies will be done as well. All right, let's get into it. So first, let's start off with anatomy of the respiratory system, and also let's start off with embryology. So basically, how the lung develops. So the lungs, essentially, they develop in the embryonic phase stage from weeks 4 to 7. Then they go through a pseudoglandular phase from weeks 5 to 17. Then a canicular phase from week 16 to 25. A saccular phase from week 24 to birth. And then alveolar phase, which happens from week 36 to the age of 8 after birth. So you can see here the structural development varies, but here is a photo that goes into more depth of every single stage from 4 to 6 weeks, then the pseudoglandular phase, canalicular phase, saccular phase, and also the alveolar phase postnatal period, which means years after birth. So these are all the weeks on the bottom y-axis, and then years are shown on the right side as well. Now let's learn a little bit about the function of the respiratory system. So the respiratory system is responsible for the exchange of oxygen and carbon dioxide between the body and the environment. It includes the lungs and airways, such as the trachea and the bronchi. Oxygen is actually inhaled into the lungs, as we know, where it diffuses into the bloodstream and binds to red blood cells for distribution to cells throughout the body. Carbon dioxide, which is a waste product of metabolism, is transported back to the lungs and then exhaled. So this exchange actually ensures that the body's cells receive oxygen for energy production and also expels carbon dioxide to maintain the proper pH levels in the blood. We'll learn a little bit more about that in the blood gas exchange slide coming up. And the respiratory system supports oxygenation and removal of waste gases. And that will help, and that's very vital for overall functioning. So there's the upper respiratory system here above, and then lower respiratory system on the bottom. You can see here the upper respiratory system includes basically what we use to breathe in, which includes our nasal cavity, our nasopharynx, oropharynx, larynx, and trachea. And then the lower respiratory system includes the bronchus. Bronchus is singular and bronchi is plural in Latin. Then there are the bronchioles, basically when that one singular bronchus breaks off into smaller bronchioles, then respiratory bronchioles, and then the alveolar ducts. And then at the alveoli and alveolar sacs is actually where the blood gas exchange occurs. And then here's the diaphragm. The diaphragm is that muscle that helps you breathe in and breathe out. And here on the left diagram, you see here the right and left lung. Remember, it's the opposite, right? As though the patient is facing you. So if the patient is facing you, then that means my right would be the patient's left if we are facing each other. Now let's talk about the breathing process. Now, of course, we are breathing and we're not really conscious about it. But let's talk about the breathing process. And I know that when we're talking about breathing, we tend to become a little bit more conscious of our breathing, even though it happens unconsciously. But basically, for the first step is pulmonary ventilation, which basically means breathing in. So pulmonary ventilation involves inhalation and exhalation, which moves air into and out of the lungs. So during inhalation, the diaphragm contracts, which expands the chest cavity and pulls air in due to the negative pressure. The exhalation is usually passive, with the diaphragm and intercostal muscles relaxing to push air out. This process is crucial for bringing oxygen into the body and removing carbon dioxide. The next step is external respiration. So external respiration is the exchange of gases between the alveoli and the blood in the pulmonary capillaries. The oxygen diffuses from the alveoli into the blood, And while carbon dioxide diffuses from the blood into the alveoli to be exhaled. And this gas exchange is driven by differences in partial pressures of the gases. So if you remember in MCAT, we learned a little bit about partial pressures and we would see the partial pressure graphs. And that is actually what helps the inhalation-exhalation process. And so the efficient external respiration maintains proper oxygen and carbon dioxide levels in the blood. The third step of the breathing process is the transport of actual gases. So oxygen is transported from the lungs to tissues by binding to hemoglobin in the red blood cells. Carbon dioxide is transported back to the lungs and dissolved in the plasma, which is bound to hemoglobin and as bicarbonate ions. Again, this is why the understanding of chemistry is so important in our undergraduate classes. And this transport system actually ensures that the oxygen is delivered to tissues and removal of carbon dioxide, which prevents acidosis. And then the fourth step is internal respiration. And internal respiration is basically the exchange of gases between the blood and the tissue cells. So here, the oxygen diffuses from the blood into the cells, where it's used for cellular respiration to generate ATP. So remember all of our metabolism and Krebs cycles and citric acid cycle, all those cycles, they are relevant here for the generation of ATP. And remember, oxygen is the final electron acceptor in the electron transport chain. So carbon dioxide, which is a waste product, diffuses from the cells and into the blood. And this exchange actually maintains the cellular function and removes toxic carbon dioxide. And in cellular respiration, it actually converts nutrients into ATP in the cells, primarily in the mitochondria. This involves glycolysis, the citric acid cycle, and oxidative phosphorylation, also the electron transfer chain, which requires oxygen as the final electron acceptor in the ETC. And that produces the most ATP. And so carbon dioxide that's produced there as a waste product is transported back to the lungs for exhalation. Because remember, if you have too much carbon dioxide in your blood, it will lead to acidosis. And so this process provides the energy for cellular functions and also maintains our body's normal homeostasis. And that is what we want. And that is just a very amazing thing that we don't even think about it. And it's happening to us unconsciously many, I would say between 16 to 20 times per minute is our respiratory rate. So multiple times per minute. So that adds up to many breaths per hour and throughout our life. Let's move on to the next slide. Yes, here we go. So this is called the respiratory tree. And the respiratory tree basically, and I know it's a lot for these diagrams. Basically, these diagrams are from first aid, and first aid is basically what we use to prepare for our board exams in medical school. And so for step one, the first of 3 licensing exams to become a board licensed physician in the United States. So this book has very interactive and very succinct graphs. So I'll explain this respiratory tree to the best of my ability. But basically on the left-hand panel, you'll see here a conducting zone. And this conducting zone, when you're thinking about the anatomy of the respiratory tract, remember we saw that bifurcation in between the lungs. Remember there's 2 lungs. So this is the bronchi breaking off into bronchioles and then also alveoli. So basically in the conducting zone, they label that as though, because that is the larger airways, of course, because it's starting off from the top, from the upper respiratory tract going down. So the large airways, they consist of the nose, the pharynx, larynx, trachea, and bronchi. And the airway resistance is highest in the large to medium-sized bronchi, whereas the small airways below, they consist of bronchioles that further divide into terminal bronchioles from large numbers in parallel. And so you can see here from the highest resistance to least airway resistance at the bottom. And so here you can warm, humidify, also filter air, but this area does not participate in gas exchange. It's also known as the anatomic dead space. If you took anatomy in high school, I remember learning about it. I didn't really understand it back then, but basically this is called the anatomic dead space. I'll show you another diagram of that later. But basically here, the cartilage and gallbladder cells, they extend to the end of the bronchi. And then there's pseudostratified ciliated columnar cells. Remember we learned about the epithelial layers and the epithelial cells and how they line all of our organs and skin. So here the pseudostratified ciliated columnar cells, they mainly make up the epithelium of the bronchus and extend to the beginning of the terminal bronchioles. And then they transition into cuboidal cells. And so this is actually very important because sometimes this part might be broken or not working, whereas this part is working just fine. So when you're thinking about diseases like cystic fibrosis, it affects the epithelial layers. In here, it's important because clear mucus and debris from the lungs, which is called a mucociliary escalator, that's actually what is done by these what is secreted by these epithelial cells. So airway smooth muscle cells, they extend to end of the terminal bronchioles, and they're sparse beyond this point. And at the bottom here, the respiratory zone, and this is essentially the lung parenchyma. That consists of respiratory bronchioles, alveolar ducts, and also alveoli, and it participates in gas exchange. This is the section, the part of the lungs that participate in the gas exchange, the smallest section. So this in this region is mostly cuboidal cells and respiratory bronchioles, and then there's simple squamous cells up to the alveoli. And the cilia, they terminate in respiratory bronchioles, and the alveolar macrophages here, they clear debris and they participate in the immune response. And so it's all very interconnected, of course. We're only talking about the respiratory system, but here you can see applications um, of the immune system. And also you can see here there's a gene called CFTR. And if that gene is defected or not being produced, then it affects the mucus that's secreted in these cells up here, and that affects someone's ability to be able to breathe properly, and that leads to a disease called cystic fibrosis. So a little bit more about lung anatomy. The right lung actually has three lobes, and the left lung has less lobes. It has two lobes and a lingula. So a lingula is actually just a homologue of the right middle lobe. Essentially, instead of a middle lobe, the left lung has a space that's occupied by the heart. So that's actually why the left lung only has two lobes and the right lung has three lobes. And so in relation to the pulmonary artery to the bronchus at each lung hilum, there's a acronym called RALS, which stands for right horizontal anterior left superior. Um, that's just a mnemonic to understand where we are anatomically. The carina is posterior to the ascending aorta. You can find the carina here, but I'll have another picture of the carina. It's actually yeah, the carina is posterior to the ascending aorta and anteromedial to the descending aorta. And the right lung is the more common site for inhaled foreign bodies because the right main stem bronchus is wider in the right lung. Of course, because the left lung has less lobes, so it is slightly smaller. So the right lung has more lobes, and so therefore it is a more common site with increased surface area for the inhaled foreign bodies like flu, and that's mainly because the right main stem of the bronchus is wider and more vertical, and it's shorter than the left. So if you aspirate like a peanut, for example, while you're supine or laying down, that peanut will usually enter the superior segment of the right lower lobe, but if you're lying on your right side, usually it would enter your right upper lobe. And if you're upright, like standing up and aspirating a peanut, you usually enter the right lower lobe, which is very interesting to think about how the position you're in changes how you would aspirate a peanut if it actually went down the wrong tube. Here you can see the carina. So here in panel A, you'll see the right lung has three lobes, the right upper lobe, right middle lobe, and right lower lobe. And on this side, you can see here the left upper lobe and left lower lobe, and there's no left middle lobe because that space is occupied by the heart that's sitting right here. And this is a chest X-ray, by the way. So instead of middle lobe, of course, we know that the left lung has a space that's occupied by the heart. And in relation to the pulmonary artery, we can see here that the carina, here, pointed out here by this white arrow, it's basically a ridge of cartilage in the windpipe. It has a very highly innervated mucous membrane, which makes it very sensitive. And the carina is located at the bifurcation of the left and right main bronchi. This will be important later on when we talk about pathology. So I'm only talking to you all about clinically relevant anatomy. Of course, this is not an exhaustive list of all the anatomy that I'm discussing, but all the anatomy that I am talking about is clinically relevant. So, the anatomy of the carina can vary between individuals, but the blood is supplied to the carina via the pulmonary and bronchial arteries. We'll discuss the lung blood supply in the next slide. But here you can see that the right lung's three lobes are the superior, middle, and inferior lobes, while the left lung's two lobes are the superior and inferior lobes. And in chest imaging, such as the X-ray, you can see in image A, the different lobes of lungs can be identified. And you can see RUL, RML, RLL, and also you can see on the left side as well. And on panel B on the right hand, that is a CT scan of patient laying down. So this is our cross section transverse. And in this CT scan shown in image B, the important anatomical structures that I can identify here are the ascending aorta, which is AAO, ascending aorta. The superior vena cava or SVC, which is part of the cardiovascular system, which we talked about last month. The pulmonary artery, PA, the descending aorta, DAO, and the carina, they're visible. The carina's location relative to the aorta is basically posterior to the ascending aorta, posterior meaning lower, and anterior medial to the descending aorta, right? So anteromedial, as in anteriorly, medially. So again, this is why knowing anatomical directions is very important, which is critical for understanding its anatomical relationships and potential implications in various clinical conditions that we'll talk about soon. So basically, understanding all these anatomical landmarks is crucial for accurate diagnosis and treatment planning in pulmonary and also cardiac care. So we'll see case studies where if you know what's normal, it's easier to identify what is abnormal. So that's why I'm showing you a normal CT and chest X-ray that we'll be able to compare later on. So the lung blood supply. The lungs basically get blood from two sources. Number one, the pulmonary circulation. This carries deoxygenated blood from the heart to the lungs to get oxygen, and then it becomes oxygenated, and then returns the oxygen-rich blood back to the heart to basically distribute it to the rest of the body through the aorta. And then the second source for the lungs blood supply is the bronchial circulation, and this provides oxygenated blood directly to the lung tissues to keep them healthy. And so these two systems ensure that the lungs have the blood that they need to function properly. On the next slide here, we'll see a little bit more detailed. Basically, the lungs and heart are very interconnected, of course, because they're anatomically near each other. But besides that, the lungs, they basically receive blood from the heart through pulmonary arteries and bronchial arteries. The pulmonary arteries carry deoxygenated blood from the right side of the heart to the lungs for oxygenation. Now, these are the only arteries that carry deoxygenated blood. Every other artery carries oxygenated blood, but the pulmonary arteries and pulmonary veins are a little bit opposite, whereas veins in the rest of the body carry deoxygenated blood. But for the lungs and heart relationship, the pulmonary veins actually carry oxygenated blood. And if you want more details on that, you can watch our prior TeleShadowing session from our cardiology month from the month of June. So, the pulmonary arteries carry deoxygenated blood from the right side of the heart to the lungs for oxygenation. And the main pulmonary artery or pulmonary trunk, it basically splits into the right and left pulmonary arteries, which supply blood to each respective lung. And the pulmonary arteries then branch out into smaller arteries, eventually becoming capillaries that surround the alveoli. And in the pulmonary capillary beds, oxygen from the alveolar gas is added to the blood, and while carbon dioxide or CO2 is removed and added to the alveolar gas. And the oxygen-rich blood then flows back to the heart through the pulmonary veins, where it's pumped to the rest of the body through the systemic circuit. And bronchial arteries, these are arteries that branch off the aorta and supply oxygenated blood to the lung parenchyma to help it survive. So remember, the lung parenchyma is that small alveolar sac that is exactly where the blood gas exchange occurs. Now, let's learn about lung physiology. So where we only talked about lung anatomy. So on the next slide, you can see here that lung volume and lung capacity, they're basically terms that describe the amount of air in the lungs at different stages of the respiratory cycle. A respiratory cycle is basically breathing in and out. So tidal volume, or TV, is the amount of air that is inhaled or exhaled during a single breath. So for a healthy adult, this is usually around 300 to 500 milliliters, or 10% of vital capacity, or VC. However, TV can increase to, or the tidal volume, it can increase to 50% during, to 50% of the vital capacity during exercise. And so actually, this is why exercise is so good for you, so important and healthy for you, because the healthier your lungs are, the better you are at breathing, and so the clearer it is. So that's why it's so important to, really, it's like the saying that I'm always reminded of, if you don't use it, you lose it. Remember when we were talking about muscle atrophy, we learned how if you don't use muscles, if you're on bed rest or hospitalized for several weeks, you will undergo muscle atrophy, which is very common. Again, this is the same thing. Use your lungs or you'll lose them. So use your lungs as much as you can, as healthy as it is for you, because your tidal volume can actually increase to 50% of your overall vital capacity during exercise, which is very good for you to do it during your exercise sessions. So a capacity is basically a sum of greater than two, or at least two physiologic volumes. So there are four volumes and four capacities. And again, I've said before, the tidal volume, where you can see here on the graph, VT, this is the tidal volume. Basically, this is the air that moves into the lung with each quiet inspiration, like 6 to 8 milliliters per kilogram, which is about 500 milliliters. And inspiratory reserve volume, you can see here IRV. This is basically air that can still be breathed in after normal inspiration. So basically, how much air can fit in your lung. And we'll talk a little bit more about it because there's this empty space here, the RV or residual volume, which is basically air in the lung after maximal expiration. So if you breathe all the way out. And again, this is called a spirometry. Basically, this is what measure this that is a tool that measures lung volume and capacity. Basically, where you breathe out as much as you can, and then there's still a little bit of air left in your lung called residual volume, and that is the air in the lung after maximal expiration, after you maximally breathe out as much as you can. So the residual volume in any lung capacity that includes residual volume cannot be measured by spirometry because you breathe out all the air you can. But ERV, or expiratory reserve volume, that is air that can still be breathed out even after normal expiration. So you take a deep breath in and out, right? If you're breathing in and out, but as much as you can, that is what can be actually measured by spirometry. Spirometry cannot actually measure residual volume. So the inspiratory capacity, IRV plus VT, is basically the equation that you use to be able to calculate how much you're able to actually breathe in. So it'd be IRV, your inspiratory reserve volume, plus your tidal volume. That will equal to the total capacity you have to breathe in air after normal exhalation. And then the functional residual capacity is, let me see if it's here. Yeah, functional residual capacity is basically equal to the RV plus ERV minus volume of gas in lungs after normal expiration. And that outward pulling force of the chest wall is balanced with inward collapsing force of the lungs. And the vital capacity is basically the IRV plus VT plus ERV. And that is the maximum volume of gas that may be expired after a maximal inspiration. So I know I'm just blurting out random equations to you right now, but it will be very relevant when you are calculating these things for spirometries. It will come back many times. I don't think this is tested on the MCAT per se, but it is tested in medical school, of course. These are the equations that you need to know. And also the total lung capacity, or TLC, you can see here. This is a very good, I would say, graph that shows you and visualizes exactly what each capacity means, right? So TLC, total lung capacity, is basically calculated by IRV plus VT plus ERV. That equals to the VC, or vital capacity, plus our RV, which is the residual volume that's left over. That's basically volume of gas that's present in the lungs after a maximal inspiration. So hopefully that makes sense. It is just a small snapshot and just an overview of what this all is, but it is good to just have at the back of your mind, knowing that there is something called lung capacity, lung volume, and spirometry and its applications that we'll see soon in our case studies. So this is actually basically a comparison between a healthy lung and a VQ mismatch. So a healthy lung, let's look at the healthy lung first and I'll explain what the VQ mismatch is. Basically, in a healthy lung, you can see here that the an anatomical dead space is equivalent to the physiologic dead space. Basically, when you're breathing in and out, dead space is basically defined as um, uh, it's a sleepy right now, but I will find out and let you all know. Basically, the physiologic dead space, I believe, is the space that's not used when breathing in and out. It's basically that holds that reserve volume. But basically, VQ mismatch is ventilation perfusion mismatch that occurs when the lungs' airflow or ventilation or blood flow, or also known as perfusion, is impaired. And that prevents the lungs from delivering oxygen to the blood efficiently. And this can happen when there is a disproportionate amount of ventilation and blood flow in certain areas of the lungs. And that can create dead space and shunt. And dead space is the volume of air. Now remember, dead space is the volume of air that doesn't participate in gas exchange because of ventilation without perfusion or blood flow. Now let's talk about the work of breathing. Now, again, this is just a snapshot of the physiology behind our lungs. Imagine, I did not think our lungs had this much, like physiology behind it, but it really does. It really does. So the work, if you remember from physics class, work is equal to pressure times volume, and that refers to the energy that's expended or oxygen consumed by respiratory muscles to produce the ventilation that's needed to meet the body's metabolic demand. And I'll repeat that. Work is pressure times volume. It basically refers to the energy that's expended or oxygen consumed by respiratory muscles to produce the ventilation that's needed to meet the body's metabolic demand. And that comprises the work needed to overcome the elastic recoil and also the airway resistance that we were talking about earlier. So basically, work is equal to force times distance, right? If you remember physics class, and that equals to pressure times volume. So here I'm corresponding two different physics equations together, and it makes sense in terms of the lungs. So when you maximize, you can actually minimize it, sorry. You minimize this by optimizing the respiratory rate and tidal volume, VT. So this actually increases in restrictive diseases. So if you have a restrictive disease, it actually increases the work required to overcome the elastic recoil achieved with increased respiratory rate and decreased tidal volume. And obstructive diseases actually cause an increased amount of work to overcome airway with resistance achieved with the decreased respiratory rate and increased tidal volume. So cystic fibrosis is an example of a restrictive disease because there's less mucus being produced, there's increased work to overcome that elastic recoil because our epithelial cells are producing that mucus in order to make it easier for us to breathe, in order to help the lungs breathe in and out. So cystic fibrosis prevents that mucus from happening, and that will mean that fibrosis is a restrictive disease. Whereas emphysema, on the other hand, is an obstructive disease, which increases the amount of work to overcome the airway resistance, because because if there is increased emphysema, then that will increase the airway resistance, and so you need to be able to increase your work for a different reason. So emphysema is an obstructive disease, whereas fibrosis is a restrictive disease. That's a very important distinction to be made. You can see here as well. The emphysema here requires more work here, and the fibrosis requires more work for a different reason, for inhalation and exhalation. Now let's talk about carbon dioxide transport. This happens in the smallest part, the alveolar sac of the lungs. Basically, blood that's rich in carbon dioxide, it travels to the heart, and the heart pumps blood to the lungs, as we know. And carbon dioxide, it basically diffuses from the blood into the alveoli. We've talked about this before, but it's good to have a visual representation as well, because it talks a little bit about acid-base balance. And essentially, the capillaries in the walls of the alveoli, they're very close to the alveoli cell layers, and that's separated by a barrier that's about 1 micron thick, or 1 micron thin, you can say. It's very, very thin, because it's just 1 micron long. The carbon dioxide can then pass through the barrier and into the alveoli in three different ways. There is dissolved gas, bicarbonate, and and I believe it's carbaminohemoglobin, and that's bound to hemoglobin and other proteins. And carbon dioxide, when it's exhaled, the carbon dioxide travels up the bronchioles, the bronchi, and the trachea in order to be exhaled. And so the carbon dioxide, when it's transported from tissues to the lungs, it can be transported in three different forms. The first form up here is HCO3. About 70% of it is HCO3. So that's why the arrow is a little bit thicker here because most of it is transported at HCO3. Basically, that transporter on the red blood, this is the red blood cell, this kidney-shaped thing. The red blood cell membrane that allows the HCO3 to diffuse out to the plasma and chloride to diffuse into the RBC. It's called chloride shift. Basically, you're switching the HCO3 with the Cl, that chloride that comes inside. It's called facilitated diffusion countertransport. I remember learning about facilitated diffusion my first year molecular biology class. I didn't know the applications of it until I realized it's actually very important for a lot of our body's physiology. The second type of carbon dioxide that can occur is the carbaminohemoglobin, or HbCO2. About 25% of the blood that's of the CO2 is excreted in this manner. It's basically bound to hemoglobin at the end terminus of the globin, and not heme. This is not hemoglobin, it's a different type of globin. And carbon dioxide, it favors the deoxygenated form, so it unloads the oxygen in this way. And then 5% of the carbon dioxide just becomes dissolved. That's it. So 70% of it happens through this facilitated transport, and then 25% here, and the rest of 5% as dissolved carbon dioxide. And in the lungs, the oxygenation of hemoglobin actually promotes the dissociation of hydrogen protons from hemoglobin. So this shifts the equilibrium toward carbon dioxide formation. Therefore, the carbon dioxide is released from red blood cells, and that's called the Haldane effect. And the majority of carbon dioxide is actually carried as HCO3 in the plasma. So it is very interesting to think about the applications of chemistry, physics, biology, all together. It's very, very interesting to see it at the molecular level inside our bodies happening right now. Now let's talk about hypoxia and hypoxemia. So hypoxia is basically decreased oxygen delivery to tissues. It's commonly due to the decreased cardiac output, and hypoxemia is called insufficient oxygenation of blood with lower partial pressure of oxygen. It can also refer to ischemia, anemia, and also carbon dioxide carbon monoxide and cyanide poisoning. And hypoxemia is basically insufficient oxygenation of the blood, which lowers the partial pressure of oxygen. And again here, the VQ mismatch is being referred to again, the right to left shunt, where basically the normal perfusion areas of no ventilation, it can be anatomic or physiologic, can be caused by a variety of factors. Basically, if there is impaired oxygen and not enough oxygen is going to you, then it can actually be, of course, we know what happens. We can only survive about 3 minutes without 3 to 6 minutes that I've seen without any oxygen. Once our oxygen stores are depleted, it leads to expiration. Now let's talk about pathology or diseases and some common diseases that pathologists treat, like pneumonia and asthma. So let's start off with rhinosinusitis. Rhinosinusitis is basically an obstruction of sinus drainage into the nasal cavity, and that can cause inflammation. So the obstruction is here, and so the inflammation will also occur there. And if there's inflammation, it can be also followed by pain over the affected area. And this typically affects your maxillary sinuses, which are located here, the maxillary sinuses, which drain against gravity due to the ostia located superomedially. And the red arrow here points to the fluid-filled right maxillary sinus in panel A. And here you can, if we know our anatomy, superior medius, the meatus, the superior meatus, that basically drains into the posterior ethmoid bone, and the middle meatus, that drains the frontal bone, the or frontal sinuses, and the maxillary, and also the anterior ethmoid. And then also the inferior meatus that drains into the nasolacrimal duct. And basically, acute rhinosinusitis is most commonly caused by viruses like rhinovirus. It may lead to a superimposed or another, like basically happening at the same time, a bacterial infection. Most commonly, like the non-typable H influenza, S. pneumoniae, M. Cataralis, and paranasal sinus infections may extend into the orbits, the cavernous sinus, and the brain, which can cause complications like orbital cellulitis, cavernous sinus syndrome, and also meningitis if it affects the brain's meninges. Meningitis just means the inflammation, itis means inflammation, and meninges, so inflammation of the brain's meninges. Another disease is epistaxis. Before medical school, I had no idea what epistaxis meant. It just means nosebleed. Epistaxis or nosebleed is most commonly occurs in the anterior segment of the nostril. And this anterior segment is actually called the Kieselbach plexus. And life-threatening hemorrhages that occur in the posterior segment, this is why knowing the arteries are very important, because the posterior segment, which includes the sphenopalatine artery, which is a branch of the maxillary artery. Again, remember, arteries, they become smaller and smaller as they become more superficial. So you have to know basically the origin of this artery, which is the maxillary artery. So common causes of a epistaxis can include a foreign body, of course, trauma, allergic rhinitis, and also nasal angiofibromas, which are more common in adolescent males. There's actually a mnemonic to remember what I just said, called Kieselbach drives his Lexus with his LEGS, legs. So that's just to remember the different arteries, like the superior labral artery, labile artery, anterior and posterior, E for ethmoidal arteries, greater palatine artery, and sphenopalatine artery. So L for labile artery, E for ethmoidal arteries of the both anterior and posterior, G for greater palatine artery, and S for sphenopalatine artery, LEGS. So the mnemonic is Kieselbach drives his Lexus, his also runs a plexus, with his LEGS legs. So this is how you'll remember all the different arteries that are associated with the Kieselbach plexus, which is the most common area in the anterior segment of the nostril where epistaxis or nose bleeding occurs. There's also head and neck cancer, which is actually very common. I would have to say that there's very common skin cancers, of course. I was reading earlier where now this is a dermatology topic, which is a sidebar, but basically a lot of these cancers occur because sunscreen is usually applied to the face and not like the lips or the neck, for example. So you can see here, the oral cavity and lip have the greatest annual incidence worldwide in head and neck cancers. And also in the US, because I would say most common causes because some people don't know that they should also be applying sunscreen to their lips. So it's mostly squamous cell carcinoma, and risk factors also include tobacco, alcohol, HPV-16 on the oropharyngeal side, EBV or the nasopharyngeal side. There's also field cancerization, like carcinogen, and carcinogen is basically anything that's a cancer-causing substance, a carcinogen. That can damage the wide mucosal area, and that can lead to the development of multiple tumors that develop independently after exposure. And a nasopharyngeal carcinoma may present with unilateral nasal obstruction, discharge, epistaxis, and the eustachian tube obstruction may actually lead to otitis media, which may or may not involve also effusion and also hearing loss. There's also laryngeal papillomatosis. That that's also called recurrent respiratory papillomatosis. Basically, a benign laryngeal tumor that commonly affects areas of stratified squamous epithelium. Again, this is very important to know the different types of epithelium layers and what they look like. Remember, there's squamous, there's cuboidal, there's columnar, and the stratified, non-stratified. So this benign laryngeal tumor, it commonly affects areas of stratified squamous epithelium, such as the true vocal cords, especially in children. especially in children. So it's associated with viruses like HPV-6 and also HPV-11. So again, a lot of this is memorization and practice, and also seeing how it can affect real life patients. The next type of disease I wanted to discuss is a deep venous thrombosis, or DVT. Basically, what happens is that there is a blood clot within a deep vein that can lead to swelling, or basically when a blood clot develops, it can lead to swelling, redness, warmth, and pain. And I'm going to show you something called the Virchow's triad, which is a very handy thing that can help you remember how these clots actually form. So thrombosis is the formation of a thrombus or a clot, a blood clot. So so these three main things that happen is called Virchow's triad: an endothelial injury, which is most common. That's why the arrow is most thick here, most common. Or abnormal blood flow, like turbulent blood flow, can also cause thrombosis, and also hypercoagulability, which means the blood, it just, if it's hypercoagulable, then it can cause blood clots as well. So basically, stasis. Stasis can occur post-op, after a long drive, after a long flight. Also, that's basically stasis means abnormal blood flow. In this context, hypercoagulability can be caused by like a defect in the coagulation cascade proteins, such as factor V Leiden. Oral contraceptive use and also pregnancy can also cause hypercoagulability. Endothelial damage can be caused by an exposed collagen that can trigger a clotting cascade because our body is very sensitive to exposed collagen. Or let's say like you have a cut that can also cause it. Of course, rare in that instance, but if it's deeper cut or there's exposed collagen, that can also trigger the clotting cascade abnormally. And when your body's on homeostasis, it can actually lead to a thrombosis, and that thrombus can travel to different areas in your body. So let's talk about pulmonary embolus, right? Because we're talking about the pulmonary system. But here you can see how the cardiac system and pulmonary system are so interconnected, because remember, all the blood is flowing through the lungs for oxygenation. So most pulmonary emboli, like if there is a DVT, they arise from the proximal deep veins of lower extremities. Like they can start off from a lower extremity like this, like iliac, femoral, or up to also popliteal veins. And a D-dimer test can be used to actually clinically rule out a DVT if the disease probability is low or moderate. So there's high sensitivity and also low specificity for this D-dimer test. And the imaging test of choice is compression ultrasound with a Doppler. And you would also actually have to use, actually, I won't discuss management for now. I think it's just important to understand the physiology behind it for now. But you can use anticoagulants like apixaban for treatment and also long-term prevention of DVTs. This is why compression toxins are so important when you're going on long flights or standing up every couple of hours, or at least every 20 minutes. That is the recommendation to avoid DVTs when someone has a sedentary lifestyle. So a pulmonary emboli, like I said before, is usually due to a thromboembolus. The most common source is deep venous thrombosis, or DVT, like I said before in the previous slide. Usually involving the lower extremity and the femoral iliac and the popliteal veins, like I said before, and most often they are clinically silent, which basically means there are no symptoms associated with it, or the patient doesn't present with symptoms at least, because the lung has a dual blood supply. Remember, there are two lungs. And number two, because the embolus could usually be small and it usually self-resolves. But a DVT can actually lead to a pulmonary embolism and there's increased chance of embolization to the lungs, because there's actually 95% of the time what happens is that the embolus forms in another place in the body and it travels to the lungs. The clinical features of a pulmonary embolus can be local pain, edema, about 50%, an edema, but 50% of the time it is clinically silent and asymptomatic. But hypercoagulable states like bed rest, like immobilization for a long period of time, a long airplane flight, that's why what could lead to someone becoming in a hypercoagulable state, because they would have abnormal blood flow. So that's why it's recommended to wear like compression stockings. So I can actually show you another picture here to sort of understand. I'm going to show you all a saddle embolus, basically. It's very interesting to me, at least. But here on the next slide, you can see here a saddle embolus. It basically is showing a dislodged thrombus that's basically straddling here the pulmonary artery bifurcation. So this is a clinical emergency because remember, this will block both lungs, not just one lung. So a patient with a pulmonary embolus is actually at increased risk for more PE as well. So you should always check for that for a patient and put them on like a blood thinner to try to make sure that these with different therapeutics, these clots can resolve. There's also a something called a paradoxical embolus. I didn't show a photo of it because it is pretty rare, but it's caused by like a beginning drive or originate from a leg DVT and pass via like the interarterial or interventricular defects, and it can gain access to systemic arterial circulation, which can be very deadly. And there's also something called a systemic thromboembolism, and most of those arise from like intracardiac mural thrombi, and they are associated with like left ventricular wall defects, which is a cardiac case, but as in it comes from the heart, but it can also, if it's systemic, it can happen anywhere, including the lungs. Now, let's talk about case studies. Now that we've talked a little bit about emboli, and how to sort of diagnose and learn a little bit about it. Now, these questions actually came from AMBOSS, so I wanted to give credit there. And a couple of photos also came from Pathoma throughout this presentation. So I will read the first case. Basically, this is a patient, and let's say you were handed a chart like this. This patient is 57 years old. You're reviewing their chart as a female, unspecified race, ethnicity. You're seeing them in the emergency department, and the chief concern from this patient is it feels like I'm running out of air. And it's very important to put the patient's chief complaint into quotation marks. In January, we actually talked about how to take an effective history, so you can actually look there to try to learn and rehash your history taking skills. But basically, the HPI, history of present illness, includes dyspnea, which basically can mean shortness of breath, cough, and pleuritic chest pain for 20 minutes. There's pain that's rated 9 out of 10. And the patient was watching TV, and these symptoms had a sudden onset. They suddenly started. This patient actually underwent surgery for a right total knee replacement 3 months ago. Their past medical history includes osteoarthritis, which probably explains why they needed to eventually get their right knee replaced. Ibuprofen for the knee pain, of course, that's actually post-op care. The vaccinations of the patient are up to date. The patient has no known drug allergies. Their social history includes they live with their husband. They have smoked a pack of cigarettes daily for 20 years, but they do not drink alcohol. So now let's visit the patient and actually see from their physical exam their objective vitals. You can see here the patient's weight and height. You can see the BMI is slightly increased. The O2 saturation is a little bit low because see, this patient is at 92% oxygen saturation out of 100% on 4 liters of nasal cannula oxygen, which is very concerning. Blood pressure is low. Respiratory rate is high. Pulse is slightly high on the high end, and patient running a slight temperature. Of course, after even looking at the vitals, I don't even just looking at the numbers, I can tell that this patient would be in acute distress and unable to lay back because they would feel lightheaded. And the neck, if I observe the patient's neck, there is a jugular venous pressure of 8 centimeters above the sternal angle. The trachea is midline. The pulmonary, there are decreased sounds bilaterally. There's productive cough with blood-tinged sputum. There's tachycardia, split S2. Remember we talked about these cardiac sounds in our last session, last month. Abdominal, this patient is obese, non-tender to palpation, normal active bowel sounds, and no hepatosplenomegaly, which basically means there's no enlargement of the spleen or the liver. When you look at the extremities, there's a tender surgical scar on the right knee, of course, because they just got their knee replaced. No edema, no tenderness, and no erythema of the right calf. The radial and femoral impulses are intact, as you can still feel them bilaterally. The patient is alert and also fully oriented neurologically. After running some diagnostic studies, the ECG showed sinus tachycardia. There 140. RSR waves in leads V1, V2, ST segment depression, and T wave inversion in leads V1, V2. The bedside echo showed a mid-segment dilation of the right ventricle, tricuspid regurgitation, and increased pulmonary artery systolic pressure. And I'll actually be highlighting what's most important here, and then this is the CT scan of the chest. Now, if you took a screenshot, if you look back and rewind the video to a normal CT chest, you can sort of compare and you can actually tell me what you think is the abnormal aspect here. There's something that's off, at least from the healthy one that we were looking at for a couple of minutes. So the question here for this case study is, given the patient's history, physical exam, and diagnostic studies, which of the following is the most appropriate treatment for this patient's condition? Pericardiocentesis, B, alteplase therapy, C, coronary angioplasty, D, endovascular stent grafting, E, piperacillin or tazobactam therapy, F, tube thoracostomy, or G, bumetanide therapy. Now, just by a process of elimination, we did not actually discuss a lot of these. Of course, we know that we're talking about the pulmonary system, so let's actually go one by one. So basically, pericardiocentesis is basically a procedure that we learned about during our cardiology month. It's basically a procedure that's used to treat patients with like pericardial effusion and also cardiac tamponade. And cardiac tamponade can manifest with dyspnea, chest pain, hypotension, and also jugular venous distension. But the CT scan actually shows something else. So I accidentally showed the answer, but we'll go over one by one. Let's actually look at option C first. The coronary angioplasty is actually used in the treatment of myocardial infarction. MI can actually manifest with chest pain, jugular venous distension, also hypotension. However, the patient's CT scan shows a vascular filling defect consistent with a pulmonary embolism. And in addition, a CT scan is typically not diagnostic in cases of MI or myocardial infarction. The stent grafting is also used for the treatment of an aortic dissection, which is cardiovascular. And I know that we are focused more on a pulmonary type of disease because it's our pulmonary month. And piperacillin tazobactam therapy is used in treatment of pneumonia, which actually manifests with dyspnea, cough, and in the setting of sepsis, you can also have hypotension. Like the patient did have hypotension or lower blood pressure, but the jugular venous distension would not be expected in a pneumonia. And in addition, the patient's CT scan actually shows a vascular filling defect, which is more consistent with a pulmonary embolism rather than like parenchymal infiltrates, which would be seen in pneumonia. And a tube thoracostomy is basically used in treatment of tension pneumothorax, which can manifest with dyspnea, pleuritic chest pain, cough, and also hypotension and jugular venous distension. But the CT scan again showed a vascular filling defect, so which is more indicative of a pulmonary embolism. And the last option choice is actually a diuretic used when treating pulmonary edema, which can manifest with dyspnea, cough, tachypnea, and jugular venous distension. But again, the CT scan that showed a vascular filling that we need to look at. So here, I'm going to show you what I highlighted that was important for my case. Let me see. Yes, I'm sorry, I froze. So here, what I highlighted that was important for this case when I was looking at it was dyspnea, cough, and pleuritic chest pain. And here, the lower blood pressure and the low O2 saturation, even when you're putting this patient on 4 liters of nasal cannula oxygen. The neck had a jugular venous pressure, and also there were decreased breath sounds. The ECG is very important, and an echo also very important to help rule out any cardiac involvement, and also the CT scan, of course, as I kept referring to. So basically, like also important was also the patient's history of an orthopedic surgery, such as like a total knee replacement is often prolonged by immobilization. And that's a significant risk factor for venous stasis. So remember we talked about if a patient is immobilized or in bed, Virchow's triad says that that is actually a huge risk factor for a embolus forming. Right. So that's actually a significant risk factor for venous stasis, especially it's very classic in patients who have had a total knee replacement. All right, for our next case, a 34, actually, I didn't actually go through alteplase therapy. So basically, alteplase therapy, because the CT scan shows evidence of a PE or pulmonary embolism, In cases of PE with also a hemodynamic instability basically means a systolic blood pressure of less than 90 millimeters of mercury. And there's also thrombolysis with like recombinant basically tissue plasminogen activators, TPA, that actually what causes a embolus, and alteplase therapy will basically reduce the risk of bleeding, and also since the patient went surgery 3 weeks ago, you usually would not give it to someone who just had surgery like a week ago or a few days ago, but because it's been 3 weeks, it would be appropriate to manage this patient with this. Alongside some anticoagulation like with heparin or warfarin or apixaban for patients with PE. But those are usually used for patients who are hemodynamically stable. So again, this is like a 3-4 step question because you have to first remember this patient has been immobilized. Because they've been immobilized, that could have led to an increased risk of a embolus. And after looking at the CT scan, you can tell and compare it to the normal and healthy lungs and be able to tell that this is definitely a pulmonary embolism and how do you want to treat that pulmonary embolism in the context of this patient's surgery. And so the best option would be alteplase therapy. Now, and this is the next case out of 3 for today. So a 34-year-old woman comes to the emergency department because of mid-sternal chest pain, shortness of breath, and cough with bloody sputum for the past 3 hours. The pain started after moving furniture at home and worsens when taking deep breaths. The patient has a history of hypertension. She has smoked 1 pack of cigarettes daily for the past 20 years. She drinks 1 to 2 glasses of wine per day, and current medications include enalapril and an oral contraceptive. Her temperature is 38.2 degrees Celsius, pulse is 110, respirations are 20, and blood pressure is 110 over 70 millimeters of mercury. And pulse oximetry on room air shows an oxygen saturation of 92%. Physical exam shows decreased breath sounds over the left lung base. There is calf pain on dorsal flexion of the right foot, and examination of the extremities shows warm skin and normal pulses. Further evaluation is most likely to show which of the following findings. So, A, thrombus in the left atrium on TEE, wedge-shaped opacity on CT scan, of the chest, widespread ST elevation on ECG, diffuse fluffy bilateral lung infiltrates on X-ray, tracheal deviation of X-ray on the chest, or decreased expiratory flow on peak flow meter. So I'm thinking just from the get-go to eliminate the choices that do not have anything to do with the respiratory system. So I would eliminate C, I would eliminate I think just C in this case because other ones are related to respiratory system. Basically thrombus formation in the left atrium most commonly occurs in patients with AFib or atrial fibrillation, and that causes abnormal contraction of the atrium leading to stasis of the blood. And while this patient does have the risk factors for AFib, like hypertension, also like alcohol use, the presentation of the patient is not very consistent with this diagnosis. And also AFib is usually asymptomatic, but it can manifest with like weakness, fatigue, and also lightheadedness. So pleuritic chest pain and hemoptysis are actually not common features of this diagnosis, so I'd actually cross out A. Let's look at decreased expiratory flow on the peak flow meter. Well, basically, like this rate, this peak expiratory flow rate, it is decreased in obstructive lung disease, and peak flow meter measurement, that's often used as a diagnostic and also a prognostic tool in patients that present with acute asthma exacerbations. So both asthma and COPD can cause dyspnea and cough, as well as increase the risk of respiratory infection. However, the sudden onset of symptoms without preceding episodic or chronic symptoms make these diagnoses much less likely, and this patient's pleuritic chest pain and hemoptysis would not be consistent with either asthma nor COPD. So we can actually cross out F and potentially E as well, because that one's talking about basically E is referring to a pneumothorax, and pneumothoraxes, they can actually manifest with sudden onset of pleuritic chest pain and dyspnea. So that actually brings us to our correct answer, which is B, because this patient actually presents with sudden onset of cough and dyspnea, hypoxemia, tachycardia, and also low-grade fever. and due to the pleural effusion and the features of DVT, which actually raised suspicion again for a pulmonary embolism. So these were two pulmonary embolism cases in a row, but I just wanted to sort of drill it in. So hemoptysis and also pleuritic chest pain further suggest that the pulmonary embolism was complicated by a pulmonary infarction. And that actually occurs when the thrombus occludes like a smaller segmental artery, and that can actually result in the inflammation of the lung parenchyma. And the typical CT finding in patients with a pulmonary infarction caused by the PE is actually a wedge-shaped opacity near the pleura that does not enhance with like contrast, for example. So that's just like a snapshot provide this answer would be correct. And of course, this finding is also seen in patients without like a non-committed pulmonary infarction, but that's out of the scope for today's lecture. So I highlighted again here the important parts of this question, even though this is a very long question, but this is what I would highlight personally if I was reading this question myself. Now, as for the last case for today, we'll be also looking at a chest x-ray, but I'll read this quickly. Um, a 55-year-old woman comes to the physician because of a 3-day history of chest pain and cough productive of blood-tinged sputum. The chest pain is sharp, stabbing, and exacerbated by coughing. 10 days ago, she had a sore throat and a runny nose. She was diagnosed with multiple sclerosis at the age of 40 and uses a wheelchair for mobility. She has smoked 1 pack of cigarettes daily for the past 40 years and does not drink alcohol. Current medications include ocrelizumab and dantrolene. Temperature is 100.2 degrees Fahrenheit, pulse 105, and blood pressure is 110 over 60 millimeters of mercury. Auscultation, or listening to the lungs, discloses a few scattered inspiratory crackles in the right lower lung, and cardiac examination shows no abnormalities. Neurologic exam shows stiffness and decreased sensation of the lower extremities, and there's diffuse hyperreflexia. Which of the following is the most likely diagnosis? So this is the chest x-ray here. Definitely not normal, right? I remember in our first week of medical school, we were given a bunch of radiology images, and we had never actually analyzed chest x-rays before, but we would be able to tell at least it's not normal looking. I don't think, I remember I showed you all a normal chest x-ray. So, which of the following is the most likely diagnosis? A, pericarditis, B, sarcoidosis, C, bacterial pneumonia, D, pulmonary embolism, E, pneumothorax, F, pulmonary edema, or G, bronchogenic carcinoma. So, this is sounding a little like you can see here, there's a fever. There are signs of there's like cough, there's tachycardia or increased, heart rate because the heart rate is 105. That would suggest a pulmonary embolism because the patient's immobilization and also history of smoking also increase the risk of pulmonary embolism that result from a DVT or deep vein thrombosis, which might go unnoticed in patients with like chronic leg pain or decreased sensation. And because the chest x-rays have limited sensitivity and specificity for pulmonary embolism, in suspected cases, they're only usually used to like rule out things. So they rule out pneumonias and they rule out like pulmonary edemas. They can also rule out pneumothorax. Um, and the diagnosis is basically, it can only be confirmed with like a CT pulmonary angiography or a VQ scan. And the non-specific X-ray findings can also indicate like a pulmonary embolism, can include like pleural effusion or atelectasis. So that's why the correct answer here would be pulmonary embolism. And here I highlighted the things that made me a little bit suspicious for pulmonary embolism: the tachycardia, the use of a wheelchair, which means this patient is immobile, the chest pain and cough that showed blood-tinged sputum, and this is actually the chest X-ray of the from the side and the CT angiography on the right of the sagittal plane of a patient with the right thoracic and flank pain, the intermittent cough, and blood-tinged sputum. And you can see here that there is a peripheral opacity or green overlay seen on the chest radiograph in the posterior basal segment of the right lower lobe, and that correlates with a area of opacification on the right of actually on the sagittal image of the CT angiogram. And you can see a wedge-shaped region as well. I believe it's here. of consolidation on a CT image, and that indicates actually a ischemic pulmonary hemorrhage or infarction. And so the embolus, which is the hypodense filling defect, I think there should have been a white arrow, but there isn't a white arrow here. That's visible with the contrast enhanced posterior basal segmental pulmonary artery. So we'll skip this case for today, and actually we will wrap up and actually do the rest of the cases next week, because we've completed our teleshadowing session for today. So next week we'll actually go through a couple of more case studies, not about pulmonary embolisms, but a little bit more applications for basically the total lung capacity and volumes. We'll learn a little bit more about the different diagnoses, different diagnosing tools like spirometries and other clinical skills and obstructive diseases. So we'll learn a little bit about all these things and also some clinical skills on how to do lung auscultations in the upcoming weeks for Pulmonology Month. So stay tuned for that. But for today, we are concluding our teleshadowing session. Thank you so much for tuning in. And as always, the quiz is now live. You will need a 70% or higher to pass and receive certification. It'll be on teleshadowing.com/certification due next week. And our next session will be on July 26th next week. Thanks so much, everyone, and take care.